Yeah.
Madam, everything okay from our side. काही प्रॉब्लेम नाही, व्यवस्थित आहे.
जर असं मागे घेतलं ना मग आपल्या दोघींचं चेहरा आहे.
IMA पुणे दिसलं पाहिजे. दिसतंय ना? Yeah.
मग आपल्याला अंधार आहे.
अंधार आहे. This is okay.
झालं. Just join the date. 57. Ready. Joining. Sir.
Good afternoon.
Good afternoon, Raju.
Good afternoon.
Good afternoon. Good afternoon.
We'll start. Dr. Karandikar sir, cardiologist also joining. Dipen sir, can we start recording?
Yes. Yes, we can start.
Thank you. Good afternoon and welcome all for this webinar on hypertension facts you must know. Welcome our today's speaker, Dr. Sachin Yadav sir, who is already present in our IMA boardroom. And Dr. Sachin Lakde is the second speaker. He's a cardiologist. He'll be coming soon. There was a World Hypertension Day on 17th of May, just 2 days back, which is observed to spread awareness of hypertension as it is diagnosed in asymptomatic patients. IMA Pune has requested doctors from various clinics and hospitals to measure BP of at least 20 persons with name, age, sex, and BP in sitting position and lying down position. We have got a good response to this campaign. The theme for this World Hypertension Day is measure your blood pressure accurately, control it, live longer. Before starting the webinar, I would like to announce future programs of IMA Pune. Just after 2 days, that is on 21st and 22nd May, we are having cricket tournaments on Nehru Stadium. So you can join that to see. There are 5 to 6 teams. So there will be a very nice. On 25th May, Wednesday, there is a webinar on cardiac pharmacotherapy. It is with 1 mmC point, and it is in the afternoon from 2 p.m. to 5 p.m. You will receive the flyer shortly. On 29 May, morning starts with IMA Foundation Day walk and run from 6:30 a.m. onwards. From 9 to 4 p.m., again, there is a CME on tobacco-free India. It is a physical CME with 2 MMC points. And from 6 p.m. onwards, there is a orchestra by Melody Monarch with old Bollywood songs. It is free to all IMA members. With these comments, I request our IMA Pune President, Dr. Meenakshi Deshpande, to give her presidential address.
Yeah, thank you, Dr. Alka. As you all know, we are at IMA Pune are formulating many programs for your involvement and your participation. So first of all, I would request all of you to come forwards to IMA and involve yourself and participate in all the activities. Like we are having a cricket match now in 21st and 22nd, and it will be the first time ever in IMA Pune that we are organizing such a big tournament. With the organizer, Dr. Kedar Patil over here, I'm sure he will invite you all. So he is here behind me. So you can all come, are all allowed in the auditorium over there. So all are invited. Second invitation will be for the IMA 94th IMA Pune Foundation Day, which we are celebrating on 29th of May in the form of a walk or a run. So we have a healthy start, followed by a healthy breakfast, and followed by an evening full of orchestra, which is free for all IMA Pune members. On 5th of June also, we are having a Vividha Gunadarshan program right from 2nd of 2 p.m. onwards to about, it will go on till about 7 to 8 p.m. So even if you are not participating, I would request you all to come forwards and be a part of an audience and cheer up our people who are taking part in this tournament and Foundation Day. The last thing which I wanted to tell you is that yes, hypertension is a silent killer. And I know that many of us, including our doctor members, may be having hypertension, but we have not measured our BP as an own. So I would request all of you to get your blood pressure measured and total in sitting position, standing position. If you feel like, get your stress test done and keep yourself healthy and happy. Even that is the main reason why this year we have started with this new concept of measuring the BP of non-hypertensive patients in your OPD. It is not only the patients, it is the relatives, the friends, your staff, your colleagues, and whoever you come in contact to. You can just give us 20 names. 20 names is a minimum number, but you can send us the list on the email ID which we have given. And you can also fill up the Google forms which are already circulated on 17th of May. And you can send us your photographs by email ID so that we will do a collage and we will give a good, nice report to Maharashtra State. So I would now welcome all of you for this CME because we have got our first faculty with us. Dr. Yadav sir is there, and I would request our secretary, Dr. Kedar, to start the proceedings.
Good afternoon, all. On behalf of IMA Pune, I welcome you all for this webinar today. We have with us an eminent physician from Pune, Dr. Sachin Yadav sir. He's done his MBBS and MD from BJ Medical College and a diploma in diabetes from Cardiff University in UK. He is the medical director of Chintamani Hospital and Cardiac Center in Bibwewadi, and working as a consultant physician, diabetologist, and critical consultant at Chintamani Hospital. He has been a teacher at point of time to us and a lecturer at Bharati Vidyapeeth Medical College. He's been a president of Pune Doctors Association in the past and active member of Hospital Board of IMA. Those who attend IMA webinars or lectures know him. He needs no introduction to IMA crowd. And with this, I would invite him for his talk on how many of us measure blood pressure correctly. Welcome, sir.
Yeah.
Thank you, IMA Pune, for giving me this opportunity and a very important talk on the management of blood pressure. As Dr. Meenakshi Deshpande ma'am, who is president of IMA Pune, told that hypertension is a silent killer. And even most of our doctors, our relatives, our colleagues, they don't check the blood pressure. And they come to the emergency room or to the cardiologist or the physician with some complications. So measuring the blood pressure is a very simple thing we can do at our clinic, we can do at our hospital, at home also. So it's a very important parameter which we have to monitor. That's why the theme of this World Hypertension Day this year is the measurement of blood pressure accurately, which is very, very important, because most of us know that we measure the blood pressure very accurately. Once you hear my lecture, you will know what are the lacunae and how to correct this lacunae. So it's very important to measure the blood pressure correctly. And by controlling the blood pressure, we can definitely prolong the life of ourselves as well as our patients. So the theme, the measurement of blood pressure accurately, control it, and live longer is a very adept theme for this World Hypertension Day. So thank you, Dr. Kedar, for giving the nice introduction. Thank you, Dr. Alka ma'am, for giving the this kind introduction of the IMA. So without wasting much of time, I am going to start the very simple and very important topic, that is how many of us measure the blood pressure correctly. So high blood pressure, as you know, is a disease of three paradoxes. This measurement of blood pressure doesn't require a very special instrument. Then it is very easy to detect. We very rarely require, or we require very basic minimum investigations for this hypertension. And there are now various drugs which are easy available throughout the country, and we can control the blood pressure very well by regular monitoring of the blood pressure and taking the regular medications. But if you see, even if it is very easy to detect, the diagnosis rates are dismal. Means only 50% of the patients, they are diagnosed to have the hypertension. Then second paradox is, it is very easy to treat, but the treatment rates are disappointing. That means patients are not taking the adequate treatment to control the blood pressure. And third thing is, the several drugs are available, but patients usually stick to one or two drugs, and they are not ready to increase the doses of the antihypertensive drugs to achieve the target levels. So these are the three paradoxes. Easy to detect, but diagnosis rates are not very good. Easy to treat, but the treatment rates are only the 25% of the diagnosis. And if you see the next slide, only the 6 to 10% of the patient, they have the very good control of the blood pressure. So if you see, the diagnosis is done in only the 25 to 50% of the patient, then the control of the blood pressure is in only half of that. That means only 12.5% of the patients, they get the control of the BP. So these treatment rates are very dismal. So what is hypertension? So why do we treat the hypertension? Because it's a vascular risk. It increases the vascular risk in the patients who have the other comorbidities. Even if the patient doesn't have the comorbidity, it will increase the vascular risk. That means these patients are more prone for the cardiovascular complications like acute myocardial infarction, unstable angina, non-aspiration IMA, then stroke, then kidney disorders. So that is the vascular risk. If the blood pressure is persistently raised, then the patients are at risk of these vascular diseases. So numerically, if the blood pressure is more than 140/90, that was the previous, or that is according to the European Society of Hypertension. But according to the American College of Cardiology, even the blood pressure of 130/80, above that is also called as hypertension. Okay, so persistent hypertension, that will increase the vascular risk, and the blood pressure more than 130/80 according to ACC, or more than 140/90 according to European Society of Hypertension, that is the hypertension. So these are the various figures. So if you check the blood pressure in office or the clinic, systolic of more than 140 and diastolic of more than 90 is we define as hypertension. ambulatory BP is done in many patients nowadays because it's easily available. So the daytime BP of more than 135/85 is the hypertension. Then usually the nocturnal BP is less, almost 10 to 20% less than the daytime BP. So nocturnal BP should be less. The systolic more than 120 or diastolic more than 70 is also called as hypertension. And if you have the average BP of 24 hours, so more than 130 systolic and diastolic of more than 80 is also called as a hypertension. So home BP, now many of our patients, they have the electronic BP machines at home. So home BP of more than 135/85 is also called as a hypertension. So we have to remember three figures. So clinic BP, home BP, or the ambulatory BP. So if we remember these three figures, and we have to check the blood pressure at multiple times and at various different times, then we can diagnose the hypertension. So it's like an iceberg phenomena. So if you say, I have already told, so only the 6 to 10% of the people, they have the control of the BP. So just like iceberg, only 1/9 of the tip of iceberg is seen. 8/9 of the this iceberg is below the water level. So it's a hidden part. That's why our president, Dr. Meenakshi ma'am, told everyone has to check your blood pressure. So this is the theme of this year. So coming to the blood pressure measurement, so you are thinking this is a very simple topic, but it's very, very important. So if you see, the Kaplan has already told the measurement of blood pressure is a very simple clinical procedure, but it is of greatest importance. Okay, so and that is done in the slopiest manner. So this is, even it appears very simple, but if you have to take the blood pressure very correctly, then we have to remember many things before taking the blood pressure. So first, blood pressure accurately was measured by the Riva Rossi. So there was a mercury manometer, this mercury column. So this was almost 100 years back. Now, even with the mercury manometer, we are measuring the blood pressure. So very little has been changed over the last 100 years. So why do we measure the blood pressure? It is not only for the diagnosis of the hypertension, but even after starting the antihypertensive medications, we have to titrate the antihypertensive doses to achieve the target level. So usually the target level is 140/90 initially, and best is the 130/80. Second important thing, we have to measure the stability of control. So blood pressure control should be stable over a period of time. So that's why we require the regular measurement of the blood pressure. And third important thing is we have to calculate the CV risk. So associated comorbid conditions like patient having the addictions, alcohol, smoking, then age is the risk factor, then dyslipidemia, diabetes mellitus, past history of any vascular event like angioplasty, stroke. So all these parameters we have to consider while calculating the CV risk. Then important thing is accurate BP measurement is a prerequisite irrespective of the any technique. So what are the blood pressure measurement devices? Now we have many electronic devices. So initially these aneroid meters were used. Nowadays they are hardly used because of the less accuracy of these meters. Then we are using this mercury manometers, but because of the concerns of mercury toxicity to the handlers, nowadays these are not available. So we have to.
Okay.
Yeah.
I request DigiShield to mute the panelists.
So this mercury manometer is now no more available because of the concerns of the mercury toxicity. But this is the most accurate way. Even if we have to standardize this electronic BP meters, then that is to be compared with these mercury manometers. Then even the electronic this BP apparatus, they are now available from various companies, but some are only few are validated according to the this British hypertension guidelines. So mercury sphygmomanometer is a very simple, accurate device. But only problem nowadays, because of the concerns of the mercury toxicity, these are not available. So we have to rely on the electronic BP machines. Then aneroid sphygmomanometers, they are very easy to carry. So most of our general practitioner, even most of doctors who do the home visits, they carry this aneroid sphygmomanometers. But the problem with this aneroid sphygmomanometer, there are jolts and bumps which affects the accuracy over time, and they are less accurate if we are comparing with the mercury sphygmomanometers. So only 33% of the or 33 to 50% of the sphygmomanometers, aneroid sphygmomanometers, they are correct. So we have to discourage the use of these aneroid sphygmomanometers. Then coming to the electronic or the automated these sphygmomanometers. So depending upon these oscillations, so the mechanism is, once we compress the brachial artery, as we release the cuff pressure, then we get the oscillations. So at the start of the oscillation, that is the systolic blood pressure, then this intensity of these oscillations will increase, and later on these oscillations will disappear. So disappearance of the oscillations is the diastolic. The start of this oscillation is the systolic BP. That's how these electronic manometers, they work. So these are the electronic BP machines. So which machines are validated by this British and Irish Hypertension Society, you can get on the net. So all machines are not validated because they have accuracy problems. So like Omron is very good. Then some machines are even British Irish Hypertension Society, they are validated. You can get on the website. Then coming to the ambulatory BP monitoring. So nowadays, many patients who are young patients, then difficult to control the hypertension, then those patients who have the wide fluctuations in the BP. So there we advise the ambulatory BP monitoring. So they are nowadays, they are very simple to wear. Then there is non-interference with the daily activities. Patient can do his daily activities by wearing this ambulatory BP monitoring, and it takes the blood pressure every half hourly during daytime and every 1 hourly during night time. The only problem, it is expensive. The cost is around 1 to 1.5 lakhs because of the software. But some patients do require for the complete diagnosis of the hypertension. So even if you are using this mercury manometers, then electronic BP machines, we have to check the hoses, we have to check the walls, even the bulbs of the this BP machine cuffs, because there may be some leakages from these various sites. So excessive leakage from the damaged cuffs, tubings, connectors, bulbs, that will reduce the accuracy. So that we have to check before taking the blood pressure. And important thing, according to the NABH guidelines, we have to check all the machines, including the BP apparatus, every yearly, and they will calibrate against the mercury sphygmomanometer. So mercury sphygmomanometer is the correct, or it is the best manometer, but it is not available nowadays. So what are the blood pressure measurement techniques? So important thing, before doing any procedure, we have to explain the procedure to the patient, because this will allay the fear, this will allay the anxiety, because fear and anxiety will increase the blood pressure. Second important thing, if the patient is measuring the blood pressure for the first time, because of the inflation of the cuff, that will cause a discomfort to the arm. That will cause a discomfort to the arm.
Mr. Dipen, yeah.
So we have to educate those patients who have the BP machines at home. We have to educate the patient the correct method of taking the blood pressure, the position of the arm, then the position of the patient. We have to explain. to the relative or to the patient himself. What are the conditions? What are the precautions before to be taken before measuring the blood pressure? So patient should not have smoked, should not have consumed alcohol, then he should not have taken the caffeinated drinks like coffee, tea, or even heavy meal in the last 30 minutes. So this is a prerequisite before taking the blood pressure measurement. Then once the patient comes to the clinic, the blood pressure should not be taken immediately. Patient should rest for at least 5 to 10 minutes before taking the BP readings. Then patient should be seated. The back should be supported. Okay, patient should be seated comfortably with the both the feet properly supported on the ground, back supported, then arm supported on the armchair. So that is important. Then legs should be uncrossed. Even if the crossing of the legs will increase the blood pressure, and both feet should be on the ground. And patient should void the bladder before measurement. So even the full bladder will increase the blood pressure. So all these are the requirement. The patient should have the empty bladder. Patient should not have the crossed legs. The both feet should be touching the ground properly. He should be seated, back supported, and arm supported. So these are the pre-requirement before taking the blood pressure. Why this is important? Because the blood pressure decreases from lying to sitting position or even the standing position. So position of the patient is also important. If you are taking the blood pressure in supine position, then you are taking the blood pressure in sitting position. And in patients who are having the postural hypertensive symptoms, there you will check the blood pressure in the standing position. Okay, so this posture of the patient is important, and we have to mention on the paper in which position you have taken the blood pressure. Then sometimes you can standardize the posture. Those patients who are not those are not taking the blood pressure in positions, there we have to standardize posture. Blood pressure.
शांत आहे ना, झोपलाय ना, ठीक आहे.
Mr. Dipen? Mr. Dipen?
Any problem?
There is some voice from the panelist or delegate requesting to mute them.
Okay, the other people are not getting muted. Okay, I'll talk with him. You can continue.
So we have to take the blood pressure in the sitting position. That is the most comfortable position to the patient. Or if the patient is supine, you can take the blood pressure in the supine position. So every visit, you have to check the blood pressure. Those patients who are already taking the antihypertensive drugs, more than 65 years of age, there we have to check the blood pressure. Patients who are diabetic and patients who get the postural symptoms like giddiness on standing or giddiness on getting up from the supine position, there we have to check the blood pressure in sitting as well as standing position. So arm support is very, very important. If the arm is unsupported, so that will cause the isometric exercise and that will increase the blood pressure. Okay, so almost 10 millimeter of systolic as well as diastolic BP can be raised if the arm is unsupported. So this is very, very important. The arm should be supported. Even the diastolic BP can increase by 10% if the arm is extended. So normal, we check the blood pressure, ask the patient to outstretch the arm. It is unsupported and we check the blood pressure in the sitting position. So that is not correct. The arm should be properly supported over the this arm of the chair. Then even the effect of this isometric exercise, it is greater in the hypertensive patients. Those patients who are already hypertensive, those patients who are already taking the beta blockers, there you will get a more rise in the blood pressure. So that reading will be false. Then which arm we have to take the blood pressure? So you can take the blood pressure in both the arms, either right arm or the left arm. But later on, we have to continue to check the blood pressure in the same arm. But if the patient is having the significant difference, suppose right arm and the left arm difference is more than 10 millimeter, then we have to do the further investigations. Like we have to rule out the stenosis of the subclavian artery. We have to rule out this aortic aortoarteritis, that we have to rule out. So arm is important. Usually those patients who are using the right arm, the blood pressure will be slightly higher in the right arm as compared to the left. Those patients who are using the left arm, the blood pressure will be slightly more in the left arm as compared to the right arm. But the difference should not be more than 10 millimeter. That is important. If the blood pressure difference is more than 10 millimeter, then we have to check the blood pressure even in the lower limbs also. Okay, so this is to rule out this aortoarteritis or the aortic. And what is the position of the manometer? So the manometer should be at the level of the heart, and it should not be more than 1 meter away from the patient. And the placing of the cuff, this is again very important. The cuff should be wrapped around the arm. Okay, the size of the cuff should be at least 80%. That cuff should cover the 80% of the arm circumference. So this is very important. If you are using the smaller cuff, that will give the higher BP readings. If you are using the larger cuff, that will give the lower BP reading. So the size of the cuff is very important. So it should cover the 80% of your arm circumference. Then lower edge of the cuff should be 2 to 3 centimeter above the point of brachial artery pulsation. So it should be 2 to 3 centimeter above the elbow. So this is again very important. Then rubber tubing should be placed inferiorly. Then antecubital fossa, you can easily put your stethoscope for the auscultations. So this is important instructions regarding the placing of the cuff. So if the patient is lean and thin, there we have to use a smaller cuff. So the usual size of the cuff is 12 by 22 centimeter. Normal adult cuff is 16 by 30 millimeter. Larger adult cuff, those patients who are obese, overweight, there we have to use a larger cuff. And patients, in patients who are where we have to check the lower limb BP, the cuff of the thigh should be 42 centimeter. So this is again very important. Okay, so the bladder length should be at least 80% of your arm circumference. If it is small, you will get a high reading. If it is large, you will get a lower BP readings. Then what to do if the patient is having the irregular pulse? Okay, so these BP measurements readings are good in electronic BP machines if the pulse is regular. But if the pulse is irregular, then these machines are not validated. There we have to take the palpatory method for the BP measurement, or we have to check with the mercury manometer. Okay, so if the mercury manometer is not available, then we have to take at least 3 BP readings, and we have to take an average of these 3 BP readings. So if the pulse is irregular, then we have to take at least 3 BP readings and average of that. Then the procedure should be thorough. Okay, we have to be silent. Patient has to be silent. Patient as well as doctor should not talk while taking the BP readings. And an important thing is we should document. Okay, if you are taking the blood pressure in the right arm, left arm, and in the lower limb, as soon as you take the blood pressure, it should be documented on the paper. Then palpatory method of BP is very important, because especially in the elderly where the patient has arteriosclerosis. Okay, arteriosclerosis, there we get a auscultatory gap or the silent gap. Okay, so when you take the blood pressure by palpatory method, the disappearance of the pulse is the systolic BP. Okay, in patients who are elderly where the arteries are stiff, so there by palpatory method you will get a systolic BP of 180, but by auscultation you will get a systolic BP of 140. This is because 140 to 180 there will be no Korotkov sound. This is called as a silent gap. So actually the patient's BP is 180 systolic. That's why we have to confirm it by the palpatory method. So always do the palpatory method of BP measurement in each and every patient, and this is very important in the elderly patients. Then how to release the pressure from the cuff? So the cuff should be deflated slowly. So at the rate of 2 to 3 millimeter per beat. So that is the expected decrease in the cuff pressure. Because if you rapidly deflate the cuff, then the recording of the systolic BP will be low and diastolic BP will be recorded high. So this is again a very important message. Then this is how we measure the blood pressure. So once the this Korotkov sound start, that is the appearance of the first Korotkov sound is the systolic BP, and the disappearance of the Korotkov sound is the diastolic BP. So usually we take the first Korotkov sound and the fifth Korotkov sound for the clinical purposes. So first Korotkov sound is the first appearance of the faint and repetitive clear tapping sound. So this will correspond to the systolic BP. Then you will get an increase in the intensity of the Korotkov sound for the phase 2 and the phase 3. They don't have any significance. Some patients, they have the abrupt muffling of the sound, which is the phase 4. And here sometimes we have to take this as the diastolic BP. Some patients have the continuation of the Korotkov sound till 0. And this condition is usually seen in pregnancy, thyrotoxicosis, AV fistulas, then patients who have the hyperdynamic circulation like mitral regurgitation, aortic regurgitation. So there we take the phase 4 Korotkov sound as a diastolic BP. So in aortic regurgitation or severe anemia pregnancy, we usually record the BP of 140/60/0. So even in aortic regurgitation, we record the BP like 180/60/0. Okay. So 60 will correspond to the phase 4 and 0 will correspond to the phase 5. So this is how we record the blood pressure. So once we document on the paper, we have to document the position of the patient, whether lying, sitting or standing, then right arm or the left arm. Okay. Then if you are taking the BP readings, right arm, left arm, or in the right lower limb, left lower limb, that we have to document. Arm circumference, that we have to document. What is the size of the bladder size, that is important. And if osculatory gap is present, this is important in elderly people. Then whether the patient is anxious, relaxed, then we have to ask the patient to measure the blood pressure readings at home, and when the patient has taken the antihypertensive drugs. So all these we have to explain or we have to document in the paper. Okay, usually we write 140/90 millimeter of mercury. Okay, but that is not correct. So it is taken in the lying down position. It is taken in the right arm. Okay, then there is no osculatory gap. Patient is relaxed, and the home BP and the clinic BP, they are matching. Patient has taken the antihypertensive drug like amlodipine at 8 a.m. and we have checked the blood pressure at 11 a.m. All this we have to check. The number of measurement is also important. If there are many differences in the right arm is suppose 140/80, left arm is 120/84. Okay, right lower limb 160/100. So if the BP readings are different, then we have to check we have to take the readings multiple times, or even you can ask the patient to take the readings at home also. Okay, or secondly, if the patient is not willing, then we can advise the ambulatory BP monitoring in such patients. If the BP reading is more than 140/90, at least 2 to 3 readings we have to take. If the difference is more than 5 millimeter in both the readings, we have to take the third readings. If the pulse is irregular, then also we have to take at least 3 BP readings. So what are the sources of error? It is not only the machine, but observer also. In fact, the maximum mistake is from the observer. Okay, but because of the this availability of the electronic machine, this error has been reduced nowadays. So you can get a sources from the individual, you can get a source of error from the devices, or you can get a source from the observer also. Then one more important thing, usually we try to round off the BP readings to the nearest zero. So that is not correct. So we have to mention the BP like 162 by 81, 144 by 86. That we have to mention, not 140 by 90. Okay, so this terminal digit preference we have to omit nowadays because we have now more correct BP machines available. Then even observer prejudice or bias, this is also important. If you don't want to stress out the patient, we tell your blood pressure is normal, it's 140 by 90, even if the blood pressure was 140 or 150 by 100. So that prejudice should not be there. There should not be any bias. So this is again important from the doctor's side. Then miscuffing we have already discussed. So if you are using the short bladder or short cuff, that will cause a raised BP. So that is called as a cuff hypertension. If the cuff is wide or too long, that will cause the underestimation of BP. So this is very, very important. Cuff size is important. So if you see so how much error can be there. So if the cuff is small, you can get a rise in BP of more than 10 to 40 millimeter. Okay, if you are tying a cuff over the clothing, especially a jerkin or sweater, then also you can get a BP readings of 1 to 40 millimeter higher. Okay, if the back is unsupported, feet is unsupported, you can get a rise in BP of 5 to 15 millimeter. If the legs are crossed, 5 to 8 millimeter. If the patient is not rested properly, 10 to 20 millimeter. If the patient is talking, doctor is talking, you can get a rise in blood pressure of 10 to 15 millimeter. If the patient is in pain, you can get a rise in blood pressure of 10 to 30 millimeter. So all these parameters we have to remember while taking the blood pressure. Okay, even the this fast respirations, so slow respiration, deep breathing, that is also has the effect on the BP. Okay, if the patient has some emotional instability or a patient is very emotional, then also you can get a wide fluctuations in the BP. Then if the patient is doing the this aerobic exercises or patient is doing the muscle training, then also you can get a differences in the blood pressure. Postprandial blood pressure is high in patients, but those patients who have the autonomic neuropathy, you can get a postprandial hypotension. The patient has consumed alcohol, tobacco. If the patient is febrile, then also you can get a rise in the blood pressure. If the bladder is full, urinary bladder is full, if the patient is in pain, that will also cause a rise in the blood pressure. And how to measure the blood pressure in lower limbs? So we have to tie the cuff at the thigh level. It should be at least 10 centimeter above the knee joint. So there we have to use the this large size cuff. So that should cover at least the 40% of the thigh circumference. So here usually the lower limb BP is 10 to 40 millimeter higher than the brachial artery. This is because large muscle mass is there in the thigh as compared to the arm. So that's why the systolic BP is at least 10 to 40 millimeter higher in the lower limb. Okay, those patients who have the coarctation of aorta, aortoarteritis, or radiofemoral delay, there we have to check the blood pressure in all four limbs. Okay, right arm, right lower limb, and the left lower limb. Then how to measure the blood pressure in children? So in children, we have to use a smaller size cuff. Then even the definition of hypertension is also different in children. So I'm not going to going into details of this method. So children's, you have to use the smaller size cuff. That is important message. Then the definition of hypertension in children is depending upon the percentile. Okay, so those patients who are having the BP more than 140 by 90 but below 95 percentile, they are called as the hypertension. Okay, and we have to check the blood pressure at least 1 to 3 weeks apart in such patients. So stage 1 hypertension is if the blood pressure is between 95 to 99 percentile in children, and stage 2 hypertension if the systolic and diastolic BP is more than 99 percentile. Okay, so in children we have to define the hypertension in the percentile. Okay, Then coming to the elderly, this is very important because many elderly people, they have the hypertension and the vascular complications are more in the elderly people. So we have to measure the blood pressure in elderly first by the palpatory method to rule out the silent gap. And in elderly, the isolated systolic hypertension is more common because the diastolic BP is low. In elderly people, the systolic BP is high. So that is called as the isolated systolic hypertension. So, and second important thing, elderly people, they also suffer from the enlargement of the prostate, where these patients are usually started on the alpha blockers. Then these patients have the various cardiac disorders. They are on the various antihypertensive drugs, diuretics. So there we have to check the blood pressure in standing position also to rule out the postural hypertension. So in elderly, we have to check the blood pressure in supine position, sitting position, and the standing position. So what is postural hypertension? So if the systolic BP drops more than 20 millimeter and diastolic BP drops more than 10 millimeter in the standing position after 2 minutes of standing, that is called as a postural hypertension. Okay, so this is important in the elderly people or those patients who have the autonomic neuropathy, those patients who have some cardiac problem like dilated cardiomyopathy, stenotic lesion, regurgitant lesion, those patients who are on the diuretics, even the Parkinsonism, Parkinson's patients, they are also on this alpha, this dopa, sin dopa. There also we have to check the blood pressure in the various postures like standing, sitting, and the supine position. Then diabetic patients or the patients who have the autonomic neuropathy, okay, long-standing diabetes, they will experience the postprandial hypertension. Okay, after the food, they will have the drop in the blood pressure, and this can be diagnosed by the ambulatory BP monitoring. Then what is called as a pseudo hypertension? So pseudo hypertension is seen in the elderly people because of the stiffness of the artery. What is called as a osseous manure. Okay, so there we have to measure the blood pressure by the palpatory method. Then if the patient has arrhythmias or the patient has irregular pulse, there we have to check the blood pressure at least 3 times, and we have to take the average of that. So in atrial fibrillation, at least 3 to 5 BP readings are required. If the patient has severe bradycardia, okay, patient has complete heart block, there we have to reduce the cuff pressure very slowly, because if you reduce the cuff pressure rapidly or according to the normal method, then you will underestimate the systolic BP and you will overestimate the diastolic BP. Okay, so especially when the heartbeats are below 40, there we have to check the blood pressure very slowly for the correct measurement. Then in pregnancy, you get a wide pulse pressure. So here the fifth Korotkoff sound is the most accurate method for the diastolic pressure, but sometimes you can get the fifth Korotkoff sound till phase 5 or till 0. Okay, so there we will record the blood pressure like 140/60/0. So in pregnancy or hyperdynamic circulations or even thyroidoxicosis, we get such types of blood pressure. Then out of office measurements, so nowadays they are advised, because in office most of these patients get TENS, what is called as a white coat hypertension. So for that we advise the either ambulatory BP monitoring or we advise the home BP monitoring. So out of office or the home BP monitoring is a better estimation of the usual blood pressure, and it better correlates with the prognosis. And second important is the ambulatory BP monitoring. So why this ambulatory BP monitoring is important? Because ambulatory BP monitoring provides information of the BP during the daily activities as well as during sleep. Okay, at home you cannot take the blood pressure during sleep, so it is taken only by the BPM. Then second important thing, the BP has a reproducible circadian pattern. Okay, so higher BP values are seen when the patient is awake, mentally and physically active. then much lower values are seen during rest and sleep. So you should get a drop of at least 10 to 20% of the BP during sleep. So this is very, very important, what is called as a nocturnal dipping. And if you get a loss of this nocturnal dipping, or if you get a rise in the nocturnal BP, so that has a higher morbidity as well as mortality. Okay, so these patients are at risk of stroke. These patients are at risk of myocardial infarction. So nocturnal dipping is physiological and it is very, very important. Okay. So this is how the nocturnal BP is seen. So during daytime or voluntary work, you get a higher BP. So during nocturnal time, you get a drop in the blood pressure, systolic as well as diastolic. So nocturnal BP should be less than 120/70. 120/70. So here you are getting the nocturnal dipping pattern, but here you are getting a rise in the nocturnal BP. So this patient will have the worst cardiovascular risk. So these patients are more prone for the cardiac disorders. These patients are more at risk of this stroke. So these are the outcome studies with the ABPM. So if you see the clinic BP, then daytime BP, which is done by the ABPM. So nighttime BP. So nighttime BP is raised, then that has the higher risk of this cardiovascular death. So in which clinical situations we advise the ABPM? So those patients in which you are suspecting the white coat hypertension, then patients who are already on the drugs but not getting control. So in such resistant hypertension, we have to take the ABPM. And patients who get a episodic hypertension like pheochromocytoma, then patients who have the autonomic dysfunction, postprandial hypertension, mask hypertension, or nocturnal hypertension, there we advise the ABPM. So white coat hypertension is when the patient sees the doctor, the blood pressure is raised. So that is a white coat hypertension. And the home BP is normal or ABPM is normal. So this usually has no risk or very slightly increased risk for the cardiovascular disorders. That against is the mask hypertension. The clinic BP is normal, but the home BP is raised. Okay, so it is opposite of the white coat hypertension. And in fact, this mask hypertension has the worst prognosis. These patients are at increased risk of the cardiovascular disorders. So if you see, this is a normal patients. They have the least cardiovascular events per 1,000 patient year. So this mask hypertension, they have the maximum cardiovascular events, or those patients who have the nocturnal hypertension, they have the worst prognosis for the cardiovascular events. So this we have already discussed, the deepest and the non-deepest. So during night time, the blood pressure should fall by 10 to 20%. The blood pressure doesn't fall, or in fact sometimes blood pressure rises, these patients are at risk for the cardiovascular disorders. Okay, cardiovascular disorder means myocardial infarction, unstable angina, stroke. These are the important complications seen in the non-deepers. So in India, the availability of the ABPM is better nowadays, but it is costly, and many patients refuse to do this ABPM. But those patients who are uncontrolled in spite of 2 to 3 drugs, those patients who are obese, diabetic, very high risk patients, there we have to do the ABPM monitoring. So home BP, we have to educate the patient regarding the proper self-measurement of the blood pressure. So home BP should be less than 135/85. That is the target for the home BP. So what are the advantages of the ABPM versus the home BP or the clinic monitoring? So in home BP, it is cheap and easily available at home. So patient can measure the blood pressure at home. So there we can diagnose the mask hypertension or the white coat hypertension. But the dipping status, nocturnal dipping or the morning surge, okay, BP variability, that is seen only with the ABPM. Okay, so those patients who have lot many complications, BP variability, the morning surge of BP. Okay, there we advise the ambulatory BP monitoring. So nowadays, many guidelines, okay, NICE guidelines, European Society of Hypertension, AHA guidelines, JNC, American Society of Hypertension, ADA guidelines, all these guidelines now recommend the ABPM. Okay, those patients who are at high risk, there we advise the ABPM. Only JNC, they are not advising the ambulatory BP monitoring. Okay, so nowadays ABPM is also important. Home BP monitoring is also important. Okay, so this was regarding the accurate measurement of the blood pressure. So thank you very much for your kind attention. Even if this topic was very, very simple, but this was very important from day-to-day practice. So thank you very much.
Dear Yadav sir, it was a wonderful lecture where you mentioned basics of taking hypertension. And I'm sure we all make these errors while measuring BP at various occasions in our clinic or at various places. And so we do have some questions in the chat box. Sir, you would like to take these questions?
Yeah, we'll take them.
So there's a question from Dr. Mrunalini Vadai. From where to refer percentile value in pediatric patients?
Yeah, it is available on the net. It is available on the net. Question.
Panelists, do they have any questions?
Yeah, I'm having one question. Can I ask Dr. Yadav?
Yes, ma'am.
Yes. So suppose in pregnancy, you find that the diastolic value goes to nearly, 10 or 20 also.
Correct.
Is there some, can we advise her? Normally we don't advise more salt to pregnant patients.
Correct.
But are we supposed to advise some salt in the diet if you get a diastolic pressure and even sometimes the systolic pressure also readings come to 100 by 60 or 100 by 40. These are the readings sometimes we get in pregnant patients. So how can we manage that?
Actually, there is no need to advise a salt intake in such patients. We have to clinically assess the patient. If the patient is asymptomatic, okay, then we don't. These patients do not require any treatment. Because in pregnancy, we get a wide pulse pressure. That is a known fact in pregnancy. Only thing we have to rule out the other associated condition. If the patient is having the mitral regurgitation, aortic regurgitation, or some fissulas anywhere in the body, that we have to rule out. So I would suggest in such patients, at least get 2D echo done in such patients.
Okay. So any other indication of 2D echo in a pregnant patient? Because nowadays we are getting few calls that patient has collapsed after cesarean section. Correct. And in that case, why 2D echo was not done in the 5th month or 6th month, when actually we haven't suspected anything during pregnancy that time?
So those patients, I would say those patients who are hypertensive before this 5th month of pregnancy, there we have to do the 2D echo to know whether the patient is having the underlying LVH. Then second, if you are suspecting some valvular disease like rheumatic valvular heart disease, patient has some murmur, okay, or if the patient has primary pulmonary hypertension, then we have to do the 2D echo in such patient. If the patient is having cardiac symptoms like recurrent chest pain, or patient is having the breathlessness, which is disproportionate to the clinical findings, there we will advise a 2D echo.
Okay, thank you. You can continue.
We'll take the second.
Yeah, we also have with us Dr. Sachin Lakde, cardiologist and friend of mine. He will be speaking with the next topic after Yadav sir's lecture. For the next topic, I invite Yadav sir again. The topic is, does hypertensive patients require investigations? So over to you, sir, for the next topic.
Is that slides, is that, madam?
Oh, this type slides. Yeah.
Yeah. So thank you, Dr. Kedar, again. And this is again a very important topic. So does hypertensive patients need investigations? Okay. So once the patient comes to us, we diagnose the patient is having hypertension and we start the treatment. So I would say this is not absolutely correct. Because some patients may be having the underlying kidney disorders, some patients might be having some hypertensive complication. So here we will do very basic investigations. Those patients comes to us with the hypertension. So basic investigations like you can do the just hemogram, creatinine, urine routine, sugar, and ECG. So these are the very basic investigation, and I would say many of our patients, if we advise these basic investigations, they will do. But those patients who are having the resistant hypertension, those patients in whom you are suspecting the complications like LVH or kidney disorders, then we have to do the further investigation. So for primary hypertension, very basic investigations are required. But for the secondary hypertension, we require many investigations. So how do we evaluate a patient with hypertension? So why we require the investigations? So important thing is we have to assess the lifestyle, whether the patient is having the stressful lifestyle, whether the patient is having patient is obese or patient is having some addictions that we have to evaluate. Then we have to calculate the CV risk factors. Okay, those patients who are having the very less CV risk factors or patients whose CV risk is very, very low. Here we can advise the lifestyle modification for 3 to 6 months, and then we can start the treatment. Okay. Otherwise, those patients who have very high risk factors, but the stage 1 hypertension, there we have to start the treatment immediately. Okay. So CV risk calculation is again important. Then we have to find out whether the patient has some identifiable cause for the hypertension. This is important in secondary hypertension. Okay. And third important thing, whether the patient has some complications because of the hypertension, like target organ damage, patient has kidney damage, patient has
We cannot hear you, Dr. Yadav. Just a minute.
No, sir, your voice is not audible. I think network problem is there.
Yeah. I'll just talk with the person. They're looking at the problem. Just 1 minute.
Meenakshi madam?
Yes, anybody?
No, ma'am, yeah, I'm here. Dr. Sachin Lakde here.
Yeah, sure.
Meanwhile, Yadav sir is connected. There was one question in chat box about the cost of ambulatory blood pressure monitoring.
Okay.
So it's like ambulatory blood pressure monitoring. It's like a device where we have to keep it for 24 hours, and approximately cost goes from 2,000 to 3,500, 4,000. Some centers charge even 4,000. It's not that costly as compared to the information it gives to us regarding. I think Yadav sir is connected.
No, you can complete your answer if you want.
So the cost is not very high as compared to what the information is given by the ambulatory blood pressure monitoring, and it's very simple, non-invasive test and very suitable for even the patients. So we have to do ambulatory blood pressure monitoring as far as possible for the diagnosis, to diagnose resistant hypertension. Yadav sir, you are back?
Yeah, we are back.
So meanwhile, we are discussing few questions in chat box, so you can continue, sir. Right.
So we have to identify the severe risk factors, then identify the causes for the high blood pressure, especially the secondary hypertension, and we have to assess the target organ damage. So these three important things we can do by doing some investigations. Okay. So back to again the basics of the medicine. We have to take the medical history. We have to do the physical examination, routine laboratory test, and the other diagnostic test. So like age, as the age increases, the blood pressure increases. Then family history of premature cardiovascular disorders. How much is the physical activity of the patients, dietary habits of the patient, smoking, alcohol addictions, and how much is the duration of the hypertension. What are the previous medications the patients are taking, the evidence of target organ damage like retinopathy, LVH, myocardial infarction, and whether the patient has previous history of stroke, coronary artery disease, or the peripheral artery disease. So all these we have to assess in the history. So what are the important clues for the secondary hypertension? If the patient gets hypertension before the age of 30, okay, or after the age of 55, there we have to look for the secondary causes of the hypertension. Okay, so below 30, usually the fibromuscular dysplasia, aortoarteritis, these are the common causes. Then above 55, you can get the atherosclerotic renal artery stenosis, or the embolism, or the cholesterol embolism, or the thrombotic embolism. Okay. Then if the patient is having the severe hypertension, if the blood pressure is not getting control, even if the 3 agents, okay, or if the patient is having uncontrolled BP in spite of one diuretic in these 3 agents, that is called as a resistant hypertension. Okay, there we have to investigate why this patient is having the resistant hypertension. If the patient has episodic hypertension, sometimes the patient is getting the severe hypertension along with headache, palpitations, sweating, there we have to rule out the pheochromocytoma or even the hyperthyroidism. Those patients who are morbidly obese, who are having the history of sleep apnea, okay, daytime somnolence, then the disturbing snoring habits, all these will come under the sleep apnea syndrome. And in this patient also, the blood pressure is difficult to control unless we advise the CPAP therapy. Okay, so all this history is important while you are assessing the patient for the hypertension. Then patients who are young, then patients who have the hypokalemia, okay, without any drug, patients who are having the muscle weakness or the muscle paralysis because of hypokalemia, there we suspect the primary aldosteronism. Then patients who are getting the recurrent pulmonary edema, patients who are having the unequal pulses, right arm BP is 140/90, left arm BP is 100/60. So there we have to rule out the aortoarteritis. Okay, then patients who get a derangement in the renal function test after starting the ACE inhibitor therapy. Okay, once you start the ACE inhibitor, the patient will have the rise in creatinine more than 25%. There we suspect the renovascular hypertension. Then patients who have the unprovoked hypokalemia, potassium less than 3.5 with metabolic alkalosis, there we suspect the primary aldosteronism. Okay, then patients who have the unequal kidneys, okay, the kidney size difference is more than 1.5, and patient is having hypertension, there also we will suspect the hypertension. Okay, so 3-4 clinical criteria: recurrent pulmonary edema, okay, then unequal pulses, rise in creatinine after ACE inhibitor or ARB therapy, hypokalemia, and unequal kidney size in patient of hypertension. These are the clinical clues where you can suspect the renovascular hypertension. And what are the risk factors? So risk factors are important. So including age, dyslipidemia, then whether the patient has microalbuminuria, macroalbuminuria, family history of hypertension, diabetes, cigarette smoking. All these are the risk factors that we have to inquire. So in India, almost 80% of the patients, they have the associated risk, additional risk factors. Like almost 40% of the patients, they have the one risk factors. 32% of the patients, they have the two risk factors like either dyslipidemia, diabetes, smoking. So all these risk factors we have to consider while starting the antihypertensive therapy. Then patients who are taking the NSAIDs, okay, those patients who are taking the decongestive therapy like pseudoephedrine or the ephedrine for this allergic rhinitis, then these drugs can increase the blood pressure. Okay, even the patients of migraine who are taking this anti-migraine therapy, okay, so they are also prone for the hypertension. And some patients might be taking the herbal medications for medications or recreational drugs like cocaine. These are also patients who are prone for the hypertension. Then if the young patient comes to us with the hypertension, then we have to check the blood pressure at least in 3 limbs. Okay, right arm, left arm, and the right leg. At least 3 limbs we have to check the blood pressure. Then even the postural BP is also to be measured, sitting, standing, and the supine position. We have to calculate the body mass index, waist circumference. We have to oscillate for the renal bruit, the examination of the thyroid gland if the patient is having obesity or patient is having the tachycardia, then examination of the fundus to rule out the hypertensive retinopathy, and we have to examine the peripheral pulses for the peripheral arterial diseases. Then what are the clinical clues that patient might be suffering from the secondary hypertension? One is the cafe au lait spots, which is seen in the neurofibromatosis, and here the patient can get the renal artery stenosis. If the right arm and left arm BP is different, then patient might be suffering from the vasculitis or the aortoarteritis. Then if the patient is having the subclavian carotid bruit, there also patient might be having the aortoarteritis or the aortoarteritis. Then if the patient is having renal bruit, that can be because of the aortoarteritis or the atherosclerotic diseases. If the patient is having persistent tachycardia or the bradycardia, that could be because of thyroid dysfunction, either thyrotoxicosis or the hypothyroidism. And if the patient is having the truncal obesity, purple striae or buffalo arm, that could be because of the this Cushing syndrome. So primary hypertension patients, they require very basic investigations. Only secondary hypertension patients, they require the thorough investigations. Okay, for the primary hypertension, the blood sugar fasting PP or HbA1c, lipid profile, creatinine, urine routine or the urine protein, and EC. So these are the basic investigations. So most of our patients, they can afford and they can do this basic investigation. Only secondary hypertension patients, they require the many investigations. So potassium electrolytes are required to rule out the primary aldosteronism. So if the potassium is raised, that can be because of the underlying kidney disorders. If the potassium is low, that can be because of the primary aldosteronism. Similarly, sodium may be higher in the patients of primary aldosteronism. Patients who are taking the diuretics, they can have the hyponatremia as well as the hypokalemia. Then albuminuria is important because this albuminuria is directly related to the cardiovascular risk. Okay, those patients who have the microalbuminuria or the macroalbuminuria, almost 50% of the patients, they are having the associated cardiovascular disease. Okay, so albuminuria is important, which can be done even on the OPD basis. If the patient has RBC cast in the urine, that will suggest the acute nephritis. Then ECG is a basic investigations. So that will suggest some STT changes or left ventricular hypertrophy, left atrial enlargement, or patient whether the patient has previous myocardial infarction, that can be seen in the ECG. Or if the patient is having the various arrhythmias like atrial fibrillation, ventricular ectopics, or the complete heart block, that can be seen on the ECG. So this is a ECG of patient who are having the left ventricular hypertrophy. So you get a ST depression with T inversion. So this is an inverted hockey stick like appearance, and you get a this R wave is more than 25 millimeter in V5 and V6. So that will suggest a left ventricular hypertrophy. Okay, so this is a ECG of entry wall myocardial infarction, ST elevation MI. So you are getting the ST elevation in the V1 to V2, V1 to V6, which is associated with the RBBB. Then this is a ECG of atrial fibrillation with the fast ventricular rate. So this is a normal ECG, P wave, QRS complex, ST segment, T wave, where you are getting the fibrillatory waves and the QRS complexes are irregular. Then here you are getting the unifocal ventricular ectopics, which can be seen in the patients who are having the electrolyte imbalance. Then this is the ECG of complete heart block, where there is no correlation between the T wave and the QRS complexes. Then what are the special investigations which are required in the secondary hypertension? So in chronic kidney disease or the coarctation of aorta, so in coarctation we require the CT angiography, which is now easily available in Pune. Then if the patient in whom you are suspecting the Cushing's disorder, or patient who are taking the long-term steroids, there we have to do the 8 or 3 cortisol levels, or in patients of Cushing syndrome, you can do the dexamethasone suppression test. Then patients who are taking the long-term drug like NSAIDs, cocaine, or patients who are taking the pseudoephedrine, you can do the drug screening. The patients who are in whom you are suspecting pheochromocytoma, the history will be episodic hypertension, palpitation, sweating. So there you can do the 24 hours urinary VMA, normetanephrines, or you can do the DOTA scan or the MIBG scan. Okay, primary aldosteronism, here you can do the aldosterone levels, or you can do the renin activity, plasma renin activity. Then if you are suspecting the renovascular hypertension, you can do the renal Doppler, or you can do the best is the CT renal angiography. That is the best. But sometimes if the creatinine is high, we cannot do the CT angiography. There we can do the either renal Doppler, or we can go for the MR angiography of the kidneys. Okay, those patients who are having the history of sleep apnea, sleep study with oxygen saturation is very, very important, because unless you correct this abnormality, the patient won't have the control of the blood pressure. And patients who are suspecting the thyroid or parathyroid disorders, there you can do the T3, T4 layers or intact PTH levels. So renovascular hypertension usually seen in the young patients, where the patient is having the coarctation of aorta or aorta arteritis, or in females we can, in females the fibromuscular dysplasia is the most common cause for the renovascular hypertension. So history, the onset of hypertension below 30 or more than 55, and patient will have the flash pulmonary edema with the normal LV function. This patient blood pressure are difficult to control. So in spite of 2-3 drugs, even 4 drugs, the blood pressure is not getting control. So these patients need investigations. You can do either renal Doppler, CT angiography, or these patients may get worsening of the renal function after starting the ACE inhibitors. So these patients should be referred to the specialist, or these patients should be referred to the cardiologist for the further management. Because some patients, 30% of the patients can get a cure of blood pressure, or they can get a better control of hypertension if the renal stenting is done. Then coming to the Takayasu's arteritis, this is common in females. You can get a multiple artery involvement. So if you palpate the peripheral arteries, Some pulses will be weak, some pulses will be absent. So that is a clue that patient might be suffering from the aorta arthritis. You can get a bruise over the carotid, you can get bruise over the subclavian or the back, and sometimes the arteries will be tender because of the vasculitis. So these are the clinical clues where you can suspect the aorta arthritis. And most of these patients will require either dilatation or stenting of the important arteries for the control of blood pressure. And if the patient is diagnosed to have vasculitis, they will require immunosuppressants or the steroids. So this is a patient who is having the coarctation of the aorta plus renal artery stenosis. Okay. So here the MRI is showing the increased aortic wall thickness, which will suspect the patient is having the aorta arthritis. Then some patients may have the atherosclerotic renal artery stenosis, and this is commonly seen in the elderly people, okay, age more than 55 years. This is also important because if you don't treat the this bilateral renal artery stenosis, this patient can progress to have the this chronic kidney disease, or this patient can have the renal failure. Okay, so almost 11% of the patient, they can progress to the end stage renal disease. So that's why we have to investigate the patients who are more than 55 years of age with the renal artery stenosis. So if you stent such patients in time, so almost 30% of the patients, they can get a cure of the renovascular hypertension, but 70% of the patients won't get, but they get a better control of hypertension after stenting of the renal arteries. Then classical picture of the fibromuscular dysplasia is the beaded type of appearance of these renal arteries. Okay, so you are getting a beaded type of appearance, which is typical of the fibromuscular dysplasia, and this is seen in the young females. And that is the most common cause of renovascular hypertension in young females. So this is a patient who had the renal artery stenosis but raised creatinine. So here MRI angiogram of renal arteries was done. So this was a typical fibromuscular dysplasia after stenting. The patient had the cure of this renovascular hypertension in the patient of fibromuscular dysplasia. Then coming to the primary aldosteronism. So patients who had the moderate hypertension with hypokalemia and metabolic alkalosis. Okay, so moderate hypertension, and that is especially the diastolic hypertension and hypokalemia and metabolic alkalosis, there you will suspect the primary aldosteronism. Okay, so simple test like ABG will give whether the patient has metabolic alkalosis, patient has hypokalemia, that can be seen on ABG itself. And if the patient has moderate hypertension, then you can suspect the primary aldosteronism. Then second investigation would be the plasma aldosterone level and the plasma renin activity. So this we have to mention specifically. Otherwise, they will do only the plasma renin levels. So we require the plasma renin activity, and this ratio is important. Okay, if the ratio is more than 30:1 with the elevated plasma aldosterone level, that is the diagnostic of primary aldosterone. Okay, so simple test like plasma aldosterone level to the plasma renin activity. And if this ratio is more than 30 with the increased levels of aldosterone, that is the diagnostic. Almost 90 to 91% sensitivity and the specificity is there. Okay, so this patient will require later on the CT scan. So this patient had the bilateral nodules in the both adrenal glands, and this can be treated with the laparoscopic surgery. So surgical removal of the adrenal tumor can be done laparoscopically. Then these patients usually require the spironolactone. This patient won't respond to the other antihypertensive drugs, but they will respond better to the spironolactone drugs. So response to the BP to the spironolactone treatment is a predictor of surgical outcome. That means those patients who respond to the spironolactone will respond to the surgical removal of the adrenal tumor. So that is an important message as far as the primary aldosteronism is concerned. Then coming to the Cushing's syndrome. So this is a rare cause. Almost 0.1 to 6% of the patients we get a 0.6% of the patients we get a Cushing syndrome as a cause for the hypertension. So it can be because of the pituitary microadenoma, or it can be because of the excess excess consumption of the steroids over a long-term period. So this patient will have the truncal obesity, there will be weight gain, moon faces will be there, purple abdominal stripe will be there. Then patient might be having the pre-diabetes or the diabetes, and patient will have the proximal muscle weakness because of myopathy, and patient will have the hirsutism and the acne. So this is how we suspect the Cushing syndrome. And simple test again for the Cushing syndrome, we can do the this 24 hours urinary this cortisol level, or you can do the dexamethasone suppression test. For that, we have to refer the patient to the endocrinologist. Then nowadays, very simple test like late night salivary cortisol level, which is a very sensitive and a convenient screening test. So it's a single test that can suggest the Cushing syndrome. Then coming to the pheochromocytoma. So this pheochromocytoma is a cause of hypertension, especially in the young people. We have seen at least 7-8 patients who come with the episodic hypertension. And that time the patient will have the symptoms of palpitation, chest pain, sweating. Okay, so that that time we suspect the pheochromocytoma, and patient might get the hypertension after consuming the tyramine containing food. Like if the patient consume beer or if patient consume cheese, that time that could be the provocating cause for this hypertension. So in pheochromocytoma, you get a raised levels of the urinary VMS, vanillin mandelic acid, or you can get a raised levels of the adrenaline or the noradrenaline. So simple test here we can advise the 24 hours urinary VMA and the serum metanephrine levels we can advise. Then coming to the coarctation of the aorta. So it's usually the congenital condition, more common in the females. So here you get a difference in the right arm BP and the left arm BP. Then some pulses might be absent, and these patients usually have the Turner syndrome. And if you do the 2D echo, this patient might be having the bicuspid aortic valve. And unless we correct, this patient might develop the left ventricular failure by age of 40, and almost 75% of the patient will die by the age of 50. That's why coarctation of aorta has to be treated. So here we are getting the rib notching, and this is usually this is how we can suspect the patient might be having the coarctation of the aorta. Then hyperthyroidism as well as hypothyroidism, both can cause the hypertension. Okay, usually hypertension causes the systolic hypertension, hyperthyroidism, and hypothyroidism usually causes the diastolic hypertension. Okay, so simple screening tech like TSH you can do, and you can get a diagnosis either hypothyroidism or the hyperthyroidism. Then patients who are having the adult polycystic kidney disease, so it's an autosomal dominant disease. So almost 50 to 70% of this adult polycystic kidney disease, they will have the hypertension. So these patients can come with the flank pain or the hematuria. Okay, so in patients who are having the resistant hypertension, we do at least the basic ultrasonography for the kidney size or this polycystic kidney disease. Then what investigations we do to rule out the target organ damage? So in the heart, the target organ damage we see in the form of left ventricular hypertrophy. Patient might have the previous myocardial infarction. Okay, our patient may have the reduced ejection fraction. The patient in the central nervous system, patient might have the previous history of stroke or the transient ischemic attack, or patient might be having the dementia. Then CKD, the important cause nowadays for the CKD is the hypertension and the diabetes. Okay, even the peripheral artery disease can be seen in the patients who are having the long-standing hypertension and hypertensive retinopathy. So peripheral artery disease is very easy to diagnose. So you can simply do the ankle brachial index. If the ankle brachial index is less than 0.9, it is usually suggestive of peripheral artery disease. You can do the arterial Doppler and you can diagnose a peripheral artery disease. So what are the indications for referral? So patients who are having the hypertensive crisis, like patient might be having hypertensive urgency or patient might be having hypertensive emergency, this patient should be referred. Then patients who are having the persistent hypertension, okay, BP more than 160/100, in spite of 3 maximally tolerated doses or the drugs, then also we have to refer the patient to the specialist or the cardiologist. Then patients who have the persistent hypertension but negative proteinuria or hematuria, there also we have to send the patients for the specialist. The creatinine is more than 2.5, or if the BP is widely fluctuating, then we have to refer the patient for the further management. And what are the cardiovascular risk factors or the risk estimations? So these are the various risk factors, like patient might be having the low risk, patient might be having moderate risk, high risk, or very high risk. So patients, if the risk is less than 1%, it is low risk. If the risk is between 1 to 5%, it is the moderate risk. If the risk is more than 5 to 10%, it is the high risk. And if the risk is more than 10%, it is a very high risk. So why we have to calculate this risk, CV risk? Because accordingly, we have to start the treatment. Okay. So those patients who have the low risk and those patients who have 1 to 2 risk factors, then we can observe the patient for at least 3 to 6 months with the lifestyle modification. But those patients who have the high risk or very high risk, even at the high normal BP or even at the stage 1 hypertension, we have to start the treatment. So this is important for grading the patient or for calculating the CV risk. So these are the various risk scores. So these are available, or you can get an app which can be downloaded from the Play Store. So primary risk score, systematic coronary risk score, or Q risk score. Nowadays, Q risk 3 is nowadays used widely. So accordingly, we can stage the patient in the low risk, moderate risk, high risk, or the very high risk. So these are the various factors which are considered, like age, diabetes, smoking, okay, then treated, untreated, BP, dyslipidemia. So this will calculate a cardiovascular risk over a period of 10 years. Okay, so this is an app, so where you can put the various parameters and you can get the risk. So this is how the patient of hypertensive retinopathy will look like. So in some patients who are having a strong familial history of hypertension, so there some patients may require even the genomic testing. So this is not available in India. So coming to the take-home message, so opportunistic screening, as our president has already told, so it's a very important. You can check the blood pressure of yourself, your relatives, your friends. So opportunistic screening is important to detect the individuals with high BP. The BP measurement techniques are very simple, but they are to be followed accurately for accurate diagnosis. That's why the message for this, or the theme of this World Hypertension Day is measure your blood pressure accurately. So this is very, very important. Different BP measurement apparatus are available. We have to take the validated BP machines for the accurate measurement of BP. Then for primary hypertension, we don't require much investigations, but for resistant hypertension and the secondary hypertension, we require many investigations, and optimal basic investigation in all hypertensive patients and advanced investigations in secondary hypertension should be ordered in limited cases by the specialist. So thank you very much.
Thank you, Yadav sir, for your talk. We have comments from Dr. Iyer, who's appreciating sir's talk. So, Dr. Atul Ambekar has asked, how reliable are electronic battery operated blood pressure measuring devices over wrist, which are being increasingly used by patients at home?
Yeah. So I would suggest, instead of the radial artery, it should be the brachial artery. Okay, that is more correct as compared to the radial artery. Because here on the radial artery, we get 2 bones, the radius and the ulna, and the compression may not be very correct. as we get the perfect compression of the brachial artery in the arm. So I would suggest this brachial artery measurement as compared to the radial artery.
We have no more questions. So I request our president, Dr. Meenakshi Deshpande, to felicitate Dr. Yadav, sir.
A very nice talk, and I think this is a basic for everybody of us to know, because unless we know the basic of BP, we will never improve on our clinical acumen, and whatever management which we are doing, which is all based upon the basic BP reading. So I would really appreciate the talk of Dr. Yadav, sir.
Thank you. So thank you very much. And this was a very basic talk. Thank you very much.
Thank you, sir. There's one last question asked by Dr. Padma here, madam. She has asked any benefit of CT angio with calcium scoring in long-term hypertensive asymptomatic? You can.
Yeah, actually, those patients who are asymptomatic, okay, but those patients who have the high risk factors like strong family history, then dyslipidemia, prediabetes, obesity, in such patients, you can go for the CT angio. The only problem with the CT angio, it has a good negative predictivity value. Okay, so those patients who have the CT coronary angio is normal, then 95% patients, they won't have the underlying coronary artery disease. But the positive predictive value, if the calcium score is high, I think it is, if it is more than 400, okay, then this patient, these patients will require the conventional coronary angiography. So those patients who are high risk patients, then CT angio can be done in such patients. Dr. Sachin Lakdai, would you like to comment on this?
No, sir. You have given me much of information about it and made it clear. It has good negative predictive value, but the positivity rate about you cannot predict. And in asymptomatic patient, that's the investigation of choice. The patient has symptoms, then why it's better to go for the conventional angiography.
Thank you, sir. For the next topic, we have with us Dr. Sachin Lakdai. He is a managing committee member of IMA Pune, a renowned intervention cardiologist practicing at Ruby, Pune Hospital, Sahyadri Hospitals, Inamdar Hospital. And he is primarily interested in primary angioplasties, primary complex coronary angioplasties, and preventive cardiology. Having more than 15 publications in national and international journals, and he's practicing at Rudeshpar Heart Clinic Care at Swargate from 4 to 8 p.m. daily, and has 3 units in Pune at Hadapsar, Vishrantwadi, Kharadi, seen by colleagues Dr. Krishna Kumar Dhoot, Dr. Akash Mutgi. He's a director and owner of Cath Lab unit at Sangli. Also involved into clinical trials related to drugs, stents, devices, and he's also an associate professor at Bharati Vidyapith Medical College and a postgraduate teacher and guide for DM and DNB cardiology students. So I welcome with all this, I welcome Dr. Sachin Lakdai, who would be speaking on control of hypertension, newer guidelines.
Thank you, sir, for that kind introduction. Thank you, IMA Pune, for giving this opportunity. And thank you, Deshpande madam and Alka madam, for giving such opportunity to talk on the very important topic. And thank you, Dr. Sachin Yadav, sir, for giving choosing the important topic regarding the hypertension. The important. Just one second. Most important point is after the how we technically correctly check the blood pressure and what all the investigations are required at what stage, which has been Yadav sir has spoken very well and guided us very clearly. Now the important topic is the how the control of hypertension, what are the newer guidelines and how they make differences in our practice and overall the patient management. Will come to know in another few slides. I need not go into the depth of the epidemiology, what Yadav sir has told about the incidence of hypertension. Just one thing I would like to point out, that 1/3 of patients are unaware that they are hypertensive. One third of patients, they are not aware that the blood pressure is not controlled, and only 1/3 of patients have been treated properly with adequate antihypertensive and with good investigations. So one third of at least 1/3 of patients are unaware. So that what Meenakshi madam has told to for all of doctors, to all of the IMA members to check the blood pressure of ourselves or nearby relatives. That if we see the incidence of hypertension, undetected hypertension will be much more. So it's important to check the blood pressure regularly and to make the people aware about the hypertension. So if we come to the diagnose, how we diagnose the blood pressure is very basic thing. At least 2 visits, 1 to 4 weeks apart. The blood pressure should be more than systolic, should be more than 140 by 90, and diastolic should be more than 90 millimeters of mercury. This is the general definition where we label the person as a hypertensive. This is for adult patient above 18 age. Yadav sir has made it very clear. There are charts for the pediatric patients below age of 18 years. But if the blood pressure is more than 160 and diastolic is more than 100, then there is no need to check recurrence. But still, I would recommend at least 2 readings should be taken for the blood pressure. So when we detect the diagnose the hypertension, then comes the confirmation of diagnosis and what all treatment should be given. This is the flow chart how we come at the arrival of the treatment part for the hypertensive patients. So what are the new recommendations for the what we normally follow, the office blood pressure measurement of the blood pressure. That Yadav sir has told how correctly we have to measure it, what should be the position of the patients, and what are the blood pressure apparatus, BP apparatus we should follow. Regarding this, depth of discussion has been done by the Yadav sir. Also about the cuff size, sir has insisted if the large cuff is there, if the appropriate cuff is not with us, then the blood pressure could be falsely read it as a low blood pressure or normal blood pressure or sometimes elevated blood pressure. So appropriate cuff size is very important in that case. Nowadays, the importance of the out of office blood pressure, but let's say out of clinic blood pressure measurement has given more insistence, or what we call as the home monitoring of blood pressure or ambulatory blood pressure monitoring. That's given the priority to diagnose the hypertension, and because invariably the clinic blood pressure will be higher side. Anybody coming to your clinic, the blood pressure will be higher side. It's shown in all studies. So there has been clearly given nowadays importance for the out of office blood pressure measurement, and the self-monitoring of blood pressure has given the importance. So Yadav sir has discussed about that, about the ambulatory blood pressure, but I have just few things. What it is, the blood pressure, ambulatory blood pressure is called as ABPM also, ABP monitoring, and the blood pressure is measured regularly at the interval of 30 minutes or sometimes 1 hour. For 24 hours, patient can undergo daily activities, he can sleep, he can do his normal activities. So this small machine is connected. The normal apparatus is connected to the arm, and this kind of computer analysis comes over the period of time. So every hour the blood pressure, every half hour the blood pressure measurement has been done, and we can see a computer analysis of graph is there. What is awake blood pressure, what is night time. Normally there is nighttime dipping pattern, that means the blood pressure in the night is dropped, and that's we all know because of the adrenaline drive is less at the sleep, and this sort of information is given if there is non-dipping pattern, if the blood pressure, when in the future this will also give what time the antihypertensive patient should take the antihypertensive. Suppose there is no nighttime dipping, or the blood pressure is elevated in the night, or the blood pressure is morning surge of blood pressure is more, that in that case the antihypertensive treatment in the night would be more suitable. So lot much of information is given by the ambulatory blood pressure monitoring. So this is one case example. We can see the how the blood pressure in the night sleep pattern, the blood pressure is elevated, and this patient would be labeled as the hypertensive patient. So this kind of analysis comes where the systolic, diastolic, mean blood pressure as well as the heart rate is evaluated in the ambulatory blood pressure monitoring. So if we see the benefits of ABPM is more reliable than isolated clinic measurement, and white coat hypertension effect, we can clarify on this. And this ambulatory blood pressure monitoring and home blood monitoring measurements add considerably to the accurate diagnosis of hypertension and the provision of the optimal care. So it also shows the ambulatory blood pressure has more predictive value than clinical blood pressure monitoring. Clinical blood pressure at the clinic, where we can see the CV mortality and morbidity is more associated with the ambulatory blood pressure. All these studies have shown in various studies that it's very clear that CV mortality and morbidity is more predictable with the ambulatory blood pressure monitoring. So few of the indications where we should do this, apart from the when we have the we want to confirm the diagnosis of hypertension. These are the few indications like white coat hypertension, as we discussed previously, masked hypertension, even isolated systolic hypertension can be diagnosed. Nocturnal hypertension, what I discussed about the night surge of the blood pressure. Resistant hypertension, just before labeling the person as resistant hypertension, we have to confirm whether the we can confirm the resistant hypertensive pattern on the ABPM. Patient with high risk features of cardiovascular events, especially the OSA, or if the patient has the diabetic CKD patients, well, we have to profile about the cardiovascular event. In those cases, we can think of doing the ambulatory blood pressure monitoring. And as Yadav sir said, suspected episodic blood pressure. Sometimes the blood pressure at your clinic will be normal, but the patient's blood pressure, the variability of the blood pressure, we come across this kind of situation also very common when the patient says my blood pressure was normal at my I'm higher at my at home, it is it's normal at clinic, then sometimes it's higher at clinic, and the blood pressure is normal at the home. So this kind of fluctuation we can clearly we can check and we can diagnose about the hypertension pattern on the ambulatory blood pressure monitoring. So even the, as I told you, sometimes the titering of the antihypertensive therapy, what time the patient should take the antihypertensive, that also remains the important part of the titering the antihypertensive therapy. Ambulatory blood pressure monitoring can give about the importance of the antihypertensive management. Then the sometimes borderline hypertension, what we talked about, the sometimes the inconclusive values might come whether to label this person as a hypertensive or no. In that case, the APPM would give us more clarity. Even sometimes the pregnancy-induced hypertension or early detection of hypertension in pregnancy, we can do this, or suspected sleep apnea confirmation. In that case also, we can do the ambulatory blood pressure monitoring. So if we see these are the values, clinic blood pressure, then home monitoring of blood pressure, daytime ABPM, nighttime ABPM, and the 24-hour ABPM. So these are the average value of 24 hours. These are the value or normal values. These are the value where the patient is labeled as the raised hypertension, raised blood pressure, and previously it used to call the pre-hypertension or high blood pressure category, or this is called optimal blood pressure. And this is the stage 1 hypertension, stage 2 hypertension. So the definition of hypertension, stage 1, stage 2 hypertension, depending on clinical blood pressure, home monitoring, ambulatory blood pressure, daytime, nighttime, and 24-hour average. This is more important nowadays than the just labeling the single value of blood pressure to be hypertensive. And these are the cutoff point. So just coming to what's normotensive, at the clinic, the blood pressure is normal. Home blood pressure is normal. That's called absolutely that patient doesn't have hypertension. Sustained hypertension at blood clinic as well as the home monitoring the blood pressure, or at ABPM the blood hypertension is there. That patient is labeled as sustained hypertension or hypertension. Masked hypertension, there is clinic the blood pressure is normal, but at the home is the patient's the blood pressure is remaining on higher side. That's labeled as the masked hypertension. White coat hypertension, we know about this phenomenon where the hypertension is blood pressure is raised at the clinic, while in the office at the home the blood pressure is normal. So see, all these values and challenges in diagnosis of hypertension are there, but what Yadav sir has told about the challenges in diagnosis of the hypertension, what normal errors we do, observational bias, the faulty equipment. But few of the things I would insist it again for awareness of all of us, that even the observational, the pressure has to be raised, systolic pressure has to raise above the pulse palpatory method more than 30 millimeters of mercury. Then lowering of the blood pressure, mercury apparatus has to be, deflation of cuff has to be there, 2 millimeters of mercury every second. And till the terminal digital preference roundel of the zeroing of the blood pressure has to be done. Otherwise, many of us have the habit that 30 millimeters or 40 millimeters, and then we even inflate above that. So it has to be a zeroing before coming taking the blood pressure. So faulty apparatus, it has to be calibrated. We have a habit of that. Once the blood pressure apparatus is taken, after many years, people don't check even the calibrate about the thing to calibrate, and that's the most common error what we all have at our clinic. So the calibration has to be done yearly for the BP apparatus. So few of the techniques, arm resting, proper size resting of the patient, what coffee, tea, tobacco has to be avoided. This has been very well explained by the by Yadav sir about the what common errors we do while taking the blood pressure. Minimum reading has to be taken, supine standing position. The cuff has to be at the heart level. That's another important point we should take care of that thing. A few of the guidelines, new guidelines, various guidelines direct for the blood pressure management. ACPHA is one of them. ESH, European Society guidelines are there. Then even the International Society for Hypertension guidelines are there. Canadian guidelines are there. So, but what JNC guidelines are there? What we follow that ACCH guidelines and JNC guidelines, which are the common guidelines what we follow for the Indian population. And a few things what they have marked. This were the in 2017, 2018, and few of the things, the classification of blood pressure and insistence for the out of hospital blood pressure measurement, and the targets for individual targets for the diabetic, high risk patients or CKD patients, and for the age, according to age they have given. And few of the things what initiation of 2 doses. What commonly we practice is to start with one antihypertensive, rather than the insistence is to start on 2 antihypertensive at low dose. So for example, what we start like telmisartan of 40 milligram for the once the hypertension is detected. What they insist on that, start with 2, or what we do is telmisartan 40 milligram, amlodipine or amlodipine 5 milligram, rather than the dose what they recommend 2 antihypertensive at low dose like telmisartan 20 milligram and 2.5 milligram of amlodipine. So that's the recommendation by the ACCAHA. And what we do is the hydrochlorothiazide as a thiazide diuretic. They insist to give indapamide or chlorthalidone. Chlorthalidone would be more preferred because it's the venodilator, arteriodilator effect rather than diuretic effect, which is more important. So, just to the blood pressure levels in JNC and the ACCHA guidelines. The normal blood pressure or optimal blood pressure less than 120, 120 systolic and diastolic 80. Hypertension, what we used to call in JNC, between 120 to 130 or less than 80 of diastolic. It's called as elevated blood pressure in ACCHA, and 130 by 130 by 139, it's called as the stage 1 hypertension in ACCHA, and above 140 it's called as stage 2, and even it's above systolic above the diastolic above the 100 and systolic above 160 is the stage 2 hypertension. So this as the basic classification. Now this is what we just to summarize, optimal or normal blood pressure is systolic and diastolic less than 120 by 80. 130, 120, in between 120 to 130 and less than systolic, diastolic less than 80 would be elevated blood pressure. That's the systolic. Stage 1 hypertension is BP between 130 to 140 millimeters of mercury, and diastolic between 80 to 90. Above 140 by 90, 140 by 100 is the stage 2 hypertension. That's the very clear definition from the ACCHA. So few slides I'll skip. What happened with this ACCHA guidelines? With definition, the antihypertensive, this is with the JNC7 definition of hypertension, and this is with the ACCHA. So this many of there is rise in the even the at 13.7% of 7% patient of antihypertensive patient would be estimated as a hypertensive patient more as compared to the JNC guidelines. So now what the highlight they do, is don't treat the hypertension once the blood pressure is 130 by 80 is very common and understandable to us. For in between 130 to 140, or diastolic between 80 to 90. If there is history of CVD, what Yadav Sara has told about the CVD risk classification, risk scoring, that's where it's available on the internet. We should classify, and a patient with diabetic hypertensive, diabetic and with CKD. This class of patient has to be treated for the antihypertensive management of hypertension has to be above 140/90, diastolic more than 90, all patients should be treated. So this was the one trial where these are the few trial. Even they tried to reduce the blood pressure below 120 systolic accord and sprint trial, very controversial trial, and this trial was stopped early. See, there was significant mortality. Lower the better, what we say as for target of for the blood pressure. But the sprint and the accord trial, that's very much clear that the mortality, all-cause mortality increases. There are incidences that stroke rate has reduced with one trial, SPS 3 trial, when the blood pressure was, but the sprint and accord trial, when the strict blood pressure decreasing the blood pressure below 120 systolic, increase the all-cause mortality, and didn't find any significant decrease in the incidence of CBA. So just the risk stratifications, Yadav sir has very nicely shown what uncomplicated asymptomatic stage 3 established high-risk factors. This chart is available on the internet, and just we have to risk stratify for the CVD risk, and treatment and target should be according to the high-risk factors. So what we have discussed, this is just summary. What is the definition of hypertension? This is the comparison of JNC, European Society. Then for elderly, the hypertension should be less than 150/90. International Society of Hypertension, AHA-ACS, ACC guidelines for the goals for the hypertension. So just to summarize, the person below 60 years or elderly without CKD, no diabetes CKD, the goal has to be 140/80, and while the person less than 60 with and without CKD, the goal has to be less than 130/80. So thank you. This was my first talk. Any questions? I think there are a few questions in chat box. Hypertension in CKD not controlled with medication. For the emergency, what can we do? Can you start case with 180/100, thinking anesthesia might reduce, or can we start with anti-G drip? This is a good question by Dr. Satyashila, and it's very important that I know when the patient has this CKD, you require 4 or 5 antihypertensive treatment, but the situation has come to you with the emergency surgery. In that case, it's better whenever you take the patient on OT, it's better to have the blood pressure optimal, because that might be the factor where the bleeding or risk of oozing would be more. So it's better to control the blood pressure by what you are saying is correct, by giving anti-G drip, and that's the management of perioperative hypertension, perioperative hypertension, and hypertensive crisis. I'll come to my next topic is on this hypertensive emergencies. It's better but to reduce the blood pressure rather than taking the risk. It's a dying emergency. Obviously, we have to take for the with this blood pressure also 180/100. but it's better to start the anti-GDF and then go ahead with the antihypertensive. Any other questions? So should I start my next topic? Kedar?
Yes, sir.
Okay.
Let me just check the questions for this.
Yeah, just check question.
Sir, we don't have any more questions.
Okay.
So can you please proceed with your next topic?
Yes. I'll finish with my next talk. I'll be a bit short on this topic because already we have exceeded the time, but I'll try to cover the maximum thing because that's also an important topic regarding the hypertensive crisis. And this is what we called as. And just 1 second, this slide is not. So as we have seen, the hypertension, despite giving so many advances in the antihypertensive treatment, many times it's inadequately controlled, and risk of approximately 1% patient of hypertension will develop the hypertensive crisis during their lifetime. But there are chance out of 100, 1% of patients with hypertension will have some hypertensive crisis in their lifetime. The annual incidence is 1 to 2 cases of hypertensive emergency out of 1 lakh patients. The risk is more with the men than female. So these are the statistics in one of the Department of Emergency Medicine, where they have studied for the 12 months, 1 year, the number of patients who visited with hypertensive crisis, urgencies, and emergencies. So coming to hypertensive emergency or hypertensive crisis, its characteristics by increasing systolic and diastolic blood pressure associated with the signs and symptoms of acute end organ damage. So important is that there is elevation of blood pressure and there is a target organ damage. So we'll come down to target, what are the target organ damage. So unless until there is a target, just elevated blood pressure won't be called as a hypertensive urgency, hypertensive crisis or hypertensive emergency, but it would the blood there has to be a target organ damage in that case. There is no threshold for the diagnosis of diagnosing what blood pressure. Even at 161 70 blood pressure with the target organ damage, there could be chances that patient is in the hypertensive crisis. Or but usually the blood pressure is between the 180 to 220 or more than that, and diastolic blood pressure is more than 120 millimeters of mercury. MAP is more than 180. And this patient requires immediately blood pressure reduction, and this patient also requires ICU care. So important is that there is target organ damage, blood pressure is more than 180 systolic and diastolic is more than 120. This patient will require ICU admission, and reduction in blood pressure has to be immediately. So there could be hypertensive encephalopathy, there could be CVA, stroke.
Just a minute, Dr. Lakde. Are your slides moving? Because I'm seeing the same slide since last 5 minutes.
Just 1 second, madam. Sorry.
Just check.
I think just I'll say.
I'm seeing that BP goal.
Just I'll change the presentation on my laptop, but I forgot.
Yeah, because we are seeing the same slide since last 5 minutes.
Yes. Sorry. Now I think slides have changed.
Yes, now we can see. Just make it full screen, sir. Yeah.
Yeah. So.
Yeah.
So this was the slide. Just one second. Sorry for that. I didn't realize that I have started with second presentation and I have changed on my laptop, but
Yes.
didn't.
Now hypertensive. You can
Yeah.
even
Yeah.
do a little bit repeat.
Okay. Just I'll
Yeah.
cut out the presentation. One in approximately incidence of hypertensive crisis is 1 out of 100 patient hypertensive patient. In spite of control of hypertension, or uncontrolled, he will have a chance of hypertensive crisis during their life. Out of 1 lakh hypertensive patients, 1 to 2% incidence will be there for the hypertensive emergencies. This is more common with male. This was the one statistic from one hospital for the 12 months follow 12 months. They have studied about the hypertensive crisis. It was 27%, hypertensive emergencies, urgencies 20%. So this was the beta statistics. That means they are very common, one of the commonest urgencies where the patient visits with for the emergency department. For hypertensive crisis, the systolic blood pressure and diastolic blood pressure is elevated more than 120, 180, 200. It's mostly above 180 millimeters of mercury. Diastolic more than 120. Mean arterial blood pressure is MAP is more than 180. And there is associated with signs and symptoms of acute end organ damage. There is acute end organ damage in terms of it could be neurological, eye problem, it could be acute renal failure that will come subsequently. And this patient require immediately blood pressure reduction, and most of them will require the ICU admission. So it's very clear that there has to be a target organ damage, acute target organ damage, and sign symptoms has to be there of acute target organ damage. There could be hypertensive encephalopathy. Patient could have a cerebrovascular accident. Patient could have acute pulmonary edema. Patient could have ACS, dissecting aortic aneurysm, pheochromocytoma, acute renal failure, eclampsia, and microangiopathic anemia could be there. So, we'll come down to this. Yadav sir has explained about the pheochromocytoma, renovascular diseases, but more commonly it's patient non-compliant to the medication is the most common reason for the hypertensive emergency. If we say the accelerated hypertension or malignant hypertension, there is severe hypertension with presence of retinopathy. There could be exudate hemorrhages in this accelerated, but there could be a papillary edema where there is a malignant hypertension. There is papillary edema in the on the fundoscopy that's called as a malignant hypertension when it's the raised blood pressure. So target organs could be the brain, heart, aorta, kidney, and placenta. That's what I have explained in my previous slide. That placenta in terms of they can have eclampsia. So few of the commonest etiology is the most common would be the inadequate control hypertension, non-compliant to the medications, and could be renovascular disease like what Yadav sir has told about the renal artery stenosis, bilateral renal artery stenosis, or fibromuscular dysplasia, eclampsia, preeclampsia, acute glomerulonephritis, pheochromocytoma, sudden withdrawal of antihypertensive, head injury, CNS trauma, some renin-secreting tumors, or drug-induced hypertension. Sometimes drugs also can have can cause a hypertension, burns, vasculitis, post-operative, or coarctation of aorta. These are the more common causes for the hypertensive crisis. See, out of we have seen the incidents, out of 100, one patient only has the hypertensive crisis. Why is this so? There are few genetic things proposed in terms of ACE and DD genotypes, and few of absence of beta or gamma subunit of sodium handling. Many of the things have been proposed. Abnormal oxidative stress, endothelial dysfunction. So all blood pressure who have elevated, must have seen many of the hypertensive patients who come with the blood pressure of 230, 240, or the diastolic blood pressure of 120, 140 diastolic blood pressure. Still, they are not affected with the there is no target organ damage. And in that case, these are the few proposed mechanism why only few of the candidate gets affects with the hypertensive crisis. The pathophysiological mechanism how there is target organ damage. I won't go into detail of this. And when we come across the patient, we have to take the detailed history, detailed physical examination. What was the pre-existing hypertension, target organ damage, how are the what is the status of the target organs, about the compliance of medication, any use of over-the-counter medication or
Lakade sir, your voice is not heard.
Any problem? Hello, Dipen.
Hello.
Hello.
Dipen, any problem is there?
I think Dr. Sachin has left. He might be having an internet issue.
Okay, so we need to call him. Dr. Kedar, can you call him, please?
Yes, I'm doing that.
Yeah.
I'll assist her. He's coming back in a while, madam. If there are any questions, Dr. Sachin Yadav sir is here with us.
Yeah. Okay, then you can start your video now so that we can see Dr. Sachin Yadav. Anybody wanting to ask questions may ask. Yeah, sure. So till Dr. Sachin Lakade joins in, if anybody is having questions, please put it in the chat box or in the question answer section. Section. Till then, Dr. Yadav, can I ask one more question?
No problem.
Just come in the center of the screen. Yes, Dr. Yadav, your talk, I think Dr. Sachin Lakade has joined back.
Yes. Yeah, sorry for that. Again, the internet was disconnected.
So you continue with your lecture, then I'll place my question later on. Yeah.
Yes, no issue. So detailed clinical examination. I think my slides are visible.
Yes, now they are visible.
Yeah,
You can see the symptoms and the end organ damage.
yes, that's this slide.
Yes.
Yeah, chest pain where we can encounter with the acute myocardial infarction, ischemia, or thoracic aortic dissection. Back pain, there we should suspect the thoracic aorta dissection. Dyspnea, where there could be desaturation, acute pulmonary edema, change in altered status, or patient can have patient can have vomiting, nausea, vomiting, seizures, or altered sensorium, delirium. Then hypertensive encephalopathy or ischemia or hemorrhagic stroke could be the possibility. So all these symptoms should be checked carefully when we have the patient who have elevated blood pressure and we are suspecting hypertensive crisis. So detailed examination regarding heart failure, CREPS, then any murmur, acute ischemic MR could be there, renal for renovascular hypertension, abdominal mass, some abdominal mass could be the possibility, or level of sensorium or detailed neurological examination has to be done. Another important is the check for the inequality in the pulses and blood pressure on both limbs that could suggest a case of aortic dissection, and saturation, and obviously the endoscopic examination for the exudate and papilledema should be checked. So though what we encounter is the epistaxis in many patients and the blood pressure, that's not really the hypertensive emergency or hypertensive crisis. Hardly we see this kind of phenomena when we have the patient of epistaxis, but we should not label them as a hypertensive emergency patient. What this Keith-Wagner-Parker classification of hypertensive and retinopathy, where papilledema with all these grades, AV nipping, copper wire, and severe AV narrowing cortical wound hemorrhages, and hard exudates, along with the papilledema is seen in this patient. This is the classical fundoscopic examination of the hypertensive grade 4 hypertensive retinopathy. So all these investigations we have to evaluate for the patient with hemogram, renal parameters, and serum electrolytes, check for microangiopathic hemolysis on the smear, do the ECG, X-ray, CT brain, MRI as on indicated. Just coming to last 5 minutes, how to manage this patient. Normalization of the blood pressure is usually not recommended, and how fast and how much to reduce it has to be given importance. We should not drastically decrease the blood pressure except for of the condition. What happens if we suddenly there is drop in blood pressure? There is it might cause acute hypoperfusion of vital organs, resulting into myocardial ischemia, infarction, hemiplegia, or renal failure. So suddenly drop in the blood pressure will cause the vital organ hypoperfusion and can lead to myocardial infarction, hemiplegia, or acute renal failure. There is autoregulation in the brain, which is shifted to the right. I'll come to that in next few slides. And if we reduce the blood pressure suddenly, there could be ischemia in the brain, where the autoregulation of brain is there in the long-standing hypertensive patients. So we have seen all these target organs are damaged. Goal is not to reduce the MAP more than 20 to 25%. Diastolic blood pressure to be reduced to 110, 100, 110, 10 millimeters of mercury. More rapid aggressive blood pressure reduction is indicated only in acute pulmonary edema and aortic dissection, and cerebrovascular damage, neurological damage. We have to slowly reduce the blood pressure. Constant infusion has to be used instead of intermittent IV bolus or sublingual. What previously we used to use sublingual nifedipine. That is outdated and we should not practice. We have to give sustained infusion of intravenous drugs to decrease the blood pressure, to control the blood pressure. Ideal, if we see what is the ideal drug, but there is no ideal drug existing. No single has all these characteristics of it should be fast acting, easily titrable, and rapidly reversible, and should be safe. No antihypertensive drug of emergency has this characteristic. Sodium nitroglyceride, one of the commonly used, but it causes the coronary steal as it causes selective, non-selective coronary dilatation. Thiocyanate toxicity could be there, and patient may have increase in chances of acute myocardial infarction. It has good immediately acting action, both short acting, though is a short acting arterial and venous dilatation. So pre and post load is decreased. So the one thing is that it comes in amber color bottle. Okay, you must have seen from the pharmacology in our medical colleges that it has to be covered. The tubing also has to be covered when we give sodium nitroglyceride. Another drug is the nicardipine. This is one of the drug used, but it has to be contraindicated in heart failure and patients with aortic stenosis. Labetalol, one of the most commonly used for hypertensive emergencies, it has selective alpha adrenergic block and non-selective beta adrenergic receptor block. And hypertensive effect takes within 2 to 5 minutes. Cardiac output is not reduced, reduces the systemic vascular resistance, and does not affect the brain, renal, or coronary blood flow, which is maintained. Less placental transfer is there. So hardly any placental transfer, I would say, and that's one of the safest to use in preeclampsia and eclampsia. So it's one of the most commonly used drug in eclampsia and preeclampsia. Metabolized by liver and is available both orally as well as IV. Ismorol is another very immediately acting, which lasts for 10 to 20 minutes. It's a cardioselective beta blocker. 16 seconds, within 16 seconds, it's onset of action, and 10 to 20 minutes, the action is there. Very useful in post-operative hypertensive crisis or hypertensive perioperative hypertension management. And it rapidly hydrolysis, not renal or hepatic independent. The dose is 0.5 to 1 milligram per kg body weight loading over 1 minute, followed by infusion of 50 microgram per kg per minute. Sublingual nifedipine, as I told previously, is contraindicated, and my request is nobody should use. Still, there are practices, in spite of so many of FDA cardiorenal committees who have recommended not to use, but still the practice, when we find the blood pressure is on higher side, the people have tendency to give sublingual nifedipine. In few of the special scenarios, myocardial infarction and myocardial ischemia, IV nitrates are more useful, and that's the recommended to lower the blood pressure. Decreases systemic vascular resistance, and preload is also reduced. It also improves the coronary blood flow. For acute cardiogenic pulmonary edema, when the pulmonary edema, which is supposed to be of cardiogenic origin, in that case also the nitroglycerin and loop diuretics are used as a for the management of the hypertensive crisis. Aortic dissection, the beta blockers and vasodilators are more used. Nitroprusside is one indicated, and hydrolyzine is contraindicated in this patients of aortic dissection, where the blood pressure is about 220, 230 systolic and diastolic of one more than 100, because more increase in blood pressure, that will increase the shear stress on the aorta, and it will increase the dissection, aortic dissection, and thus we should reduce the blood pressure to 100 millimeters of mercury as early as diastolic blood pressure as well as systolic blood pressure has to reduce systolic below 80, diastolic below 80, and systolic around 100 to 110 millimeters of mercury as early as possible. So for ischemic stroke, the blood pressure has to be brought down within 3 to 4 days, not very rapidly. There, what happens if there are lesions in the brain area? It causes more ischemic damage, and then that will cause. This diagram explains why chronic hypertension, there is right shift in hypertension. With the sudden increase this right shift of chronic hypertension, that will cause cerebral autoregulation is shifted to right side, and this will patient will have more neurological damage than getting the benefit of reducing the hypertension. So hypertensive encephalopathy, obviously it is the lethal complication, and it could be global nephropathy or eclampsia would be the cause. It causes more blood pressure, excessive increase in cerebral blood flow, hyperfiltration, cerebral edema is the mechanism what is proposed. So coming down to eclampsia, which is one of the common thing, how should we manage the eclampsia? And it's one of the 12% of pregnancy complicate this, and the maternal mortality is very high in that case. Volume expanders and magnesium sulfate has to be given for as a prophylaxis for the seizure. We know dose of the magnesium sulfate 4 to 6 milligram in dextrose or 15 to 20 millinips, and 1 to 2 gram per hour should be the infusion rate, where we have to monitor about the deep tendon reflexes and the urine output every hourly. It has to closely monitor the patient, and antihypertensive has to target the systolic blood pressure. We should keep between below 160, and diastolic blood pressure immediately should get down as early as possible. The most devastating complication is the intracranial bleed, hemorrhages, and alpha-methyl hydrolyzine and the IV labetalol nicardipine are the drug of choice. Again, the nifedipine has to be sublingual nifedipine has to be avoided, and nitroprusside should not be used in this case, and even the ACE inhibitor has to be avoided. So few of the antihypertensive hypertensive emergency is due to catecholaminergic excess. These are one of the rare, but when they encounter, it's very difficult to treat, especially when the clonidine, like centrally acting antihypertensive, used to be, or we hardly used these days clonidine, but even sometimes we have seen the pheochromocytoma patients, cocaine intoxication, some abuse of sympathomimetics drug, and the post-operative hypertension, what we have seen previously. So this chart how the sodium nitroprusside nicardipine to be used for the as a in hypertensive emergencies. So take-home message would be most common causes for hypertensive crisis is undiagnosed, untreated, inadequately treated hypertension. Differentiation from hypertensive urgency and emergency, where the emergency or hypertensive crisis, there is targeted organ damage that has to be checked, and appropriate IV antihypertensive treatment has to be started for the patients with hypertensive crisis. And the sublingual nifedipine and the sublingual nifedipine or oral nifedipine has to be avoided in all sorts of hypertensive patients or even in hypertensive crisis, including eclampsia. Thank you. Any questions?
Thank you, Dr. Sachin Lakre, sir. There is a question by Dr. Nitin Jadhav. What is the drug of choice for accelerated hypertension in pre-hospital setup before referring patient to tertiary care hospital?
So it's one of the good question and very commonly encountered by all the practitioners. Suppose there is a patient of accelerated hypertension, means the blood pressure is 180, systolic, diastolic is 110, 120, with no end organ damage. Suppose the accelerated hypertension means there is no end organ damage. So this patient doesn't require immediately blood pressure reduction. So you can give the routine antihypertensive dose like amlodipine, or and there is no urgency or emergency in treating this hypertension. So just give amlodipine, or if the renal parameters are normal, we can even give the telmisartan for this patient. No need for giving the nifedipine or any other drug which will reduce. There's no target on organ damage, no? So we need not worry about the hypertension to reduce it to normal as early as possible. There is, I think, one more question. What is criteria to add diuretic in treatment of hypertension? That's a good question, and Shubha Jatar madam has asked about that. So the role of diuretics in hypertension, we use the diuretic, we use the loop diuretics, and the drug of choice is the chlorthalidone nowadays, rather than hydrochlorothiazide. There is no role for the diuretics like furosemide or torsemide as an antihypertensive drug for long-term management of hypertension. And in that case, the chlorthalidone is preferred over the hydrochlorothiazide or even indapamide. It's not the diuretic dose, but it's the vasodilatory action of these medications are important, and they come as a second line of drug, what is calcium channel blocker or ARBs, AC inhibitors remains the first choice of drug, like ramipril, telmisartan, olmesartan, or calcium channel blocker like amlodipine or cilnidipine, benidipine. They come as the first line of antihypertensive. To second line of drug comes the hydrochlorothiazide or the chlorthalidone kind of diuretics. So they are second line, and they are first choice in the elderly patient of hypertension. So whenever the patient of hypertension are the elderly patients of hypertension are there, they are the first choice of drug. Don't worry about the diuretic effect. Sometimes we are fear to give it in the night, like telmisartan and chlorthalidone combination or hydrochlorothiazide. They don't cause urinary frequency also, because the mechanism of action is not the diuresis, but is the vasodilatory effect. In that case, we can give the patient the hydrochlorothiazide or chlorthalidone even in the night. And for acute pulmonary edema, we to reduce the blood pressure or hypertensive crisis, we can give IV diuretic, loop diuretic like furosemide or torsemide as a IV diuretic. That's the only role for the for a role as a diuretic play in treatment of management of hypertension.
Dr. Lakre, there is one more question. What is the criteria to add diuretic in treatment of the drug of choice for hypertension with pancreatitis and hypertriglycerides?
Okay, so pancreatitis, if the renal parameters are normal, then we can add ACE inhibitors or ARBs. To that, we can add the calcium channel blockers. Beta blockers comes as the third choice of drug. Even we can add a diuretic hydrochlorothiazide or chlorthalidone, indapamide. And hypertriglyceridemia, or we should add, if the pancreatitis is there, obviously statins, then fenofibrates can be added. There is now one more new drug, lipaglyn, where this saraglutazole drug, where it can manage the diabetic hypertriglyceridemia. So this is the sequence: the ACE inhibitor, ARBs, calcium channel blocker, diuretics, and beta blockers, and then we can, and also we can add the statins and the fenofibrates. So I think, Kedar, one more question is there.
In case of inaccessibility to IV medication, which is the safe oral drug in case of hypertensive emergency as a stopgap treatment?
Yeah, that's a good question. So most safest drug in that case would be the calcium channel blocker, like the amlodipine. It will take time for its action. Variable absorption will be there, but it's one of the good sustained control of the hypertension. Second would be the ARBs like ARB like telmisartan or olmesartan, which also has good hypertensive effect, a sustained hypertensive effect, and predictable. But provided the renal parameter has to be normal, we cannot use in the eclampsia or so. And it's better to avoid in patients with the this kind of medications in the patients of the strokes. So it's we can give it, but we have to be very careful about this drug. So safest would be the calcium channel blockers like amlodipine. If we are not accessible to the IV medications immediately.
One more question: which beta blocker is preferred in diabetic patients?
Which beta blocker is preferred?
In diabetic patients.
So, as such, this is another good question, that even the all guidelines don't prefer a beta blocker as first line of drug as a antihypertensive. It comes as a third or fourth add-on drug when the blood pressure is not controlled by the conventional calcium channel blocker, ACE, ARB, or diuretics. In that case, the fourth drug of choice would be the beta blocker. Unless until they compelling use for the patients of ischemic heart disease or chronic coronary syndrome or acute coronary syndrome or post myocardial infarction or post LV dysfunction, where the ejection fraction has dropped down more than 45%, or even sometimes patients of congestive heart failure. Those are the only indications to start beta blocker as first choice as a antihypertensive. In preferred antihypertensive in diabetic, as such, there is no choice. You can give metoprolol, you can give carvedilol, we can even give the nebivolol. These all are the drugs we can use easily for in patients of diabetes.
Dr. Lakre sir, thank you for your informative lecture. I'm sure the delegates would have engrossed, they have been enlightened with adequate knowledge about hypertension management. With this, we come to the end of this webinar. On behalf of IMA Pune, I request our President, Dr. Meenakshi Deshpande, to felicitate Dr. Sachin Lakde virtually with this Uparna.
This will be an Uparna for you. Dr. Sachin, you are
Thank
welcome to IMA Pune.
Oh, no, madam. No, I was occupied with some work. I was stuck in procedure.
Personally now.
But, no. Sorry, I couldn't come today there to deliver
Okay,
this.
but you come in the
Yes, sure.
We are here daily from 4 to 6 p.m.
Yes, no issue. Yes.
Thank you for the excellent talk. Actually, I wanted to comment about the two things which you have highlighted are very important. Is not to use a sublingual nifedipine. And I think that point is the best take-home message of today's webinar. Because there are yet some people in rural peripheral areas who are using that age-old technique to bring down the blood pressure, and even that may be the cause of catastrophes.
Yeah.
So that was a good take-home message and the best one. Thank you.
We also thank Dr. Sachin Yadav sir, who has been present here throughout the webinar to answer any of your queries. Thank you, sir. And before we end this, I would like to make two important announcements. Day after tomorrow, on Saturday and Sunday, we have cricket matches at Nehru Stadium. It's a leather ball tournament. So all members, please do join and see the fitness of doctors. And on 29th, we have a morning marathon and a walk at Matre Bridge, DP Road area. So please do join these two events in large numbers. And I request our secretary, Dr. Alka Shirsagar Madam, to end the webinar.
Yes. Thank you, Dr. Kedar Patil sir. For today's webinar, I think there were maximum people, 157 I have seen, maybe more also, because we have not seen panelists also. So it was a very good response with all interactive sessions. So I thank you, Dr. Sachin Yadav sir, as a convener and faculty, and Dr. Sachin Lakde sir as a faculty. So thank you very much, and I thank Dipen DigiShield, Dipen sir, Mr. Dipen Mehta from DigiShield for conducting this technical issue. So thank you very much.
And see you all for the Foundation Day celebrations and also for the cricket match.
Yes.
So we expect all the members to participate actively and come over here.
Thank you. Mr. Deepan, you can conclude the session now.
Thank you.
Thank you.
Thank you.